Welcome, everybody. We'll be starting the program in 2 minutes. We're just waiting for people from around the world to all sign in, and it takes about 2 minutes. If you're just joining us, we're waiting another minute or so to start the program as people sign in.
Dr. Mitrani, the trickle at the turnstile slowed down. I think you can start.
I want to welcome you all to the 2021 Miami Valves Conference. We have an exciting lineup, and we're featuring a discussion with Dr. Hugh, Professor of Medicine and Cardiology and Director of the Arrhythmia Service at Johns Hopkins Hospital. It's our honor and pleasure to have him. Miami Valves, as you know, is a yearly conference we have that covers various aspects of interventional and structural heart disease, including cardiac electrophysiology. This year, the meeting is virtual. But next year, we plan to have an in-person meeting from February 3rd to February 5th, 2022. So please mark that on your calendar. It'll be another fun and exciting conference next year. This conference, of course, is virtual, as we all are struggling under various pandemic restrictions. Nevertheless, that doesn't stop us from having excitement and fun fact-filled conference this year. By using Zoom, however, we have the advantage of having an international conference with participants from all 6 continents. Only Antarctica is not represented. So welcome to you all from all over the world. Bienvenido. I want to thank our supporters. Without the financial support of our sponsors, these conferences would not be possible. We have our platinum supporter. We have our gold supporters. And we have our silver supporters. So I want to introduce Dr. Hugh Calkins. Dr. Calkins is Professor of Cardiology and Director of the Electrophysiology Lab and Arrhythmia Service at the Johns Hopkins Hospital. He's an internationally recognized expert on catheter ablation, atrial fibrillation, syncope, and arrhythmogenic right ventricular dysplasia. He received his MD degree from Harvard and trained at Mass General and Johns Hopkins. He joined the faculty and received further training from Dr. University. Dr. Calkins, I remember him for a New England Journal of Medicine article when SVT ablation was first reported back almost 30 years ago now. And he certainly has had a tremendous career in the field of electrophysiology and catheter ablation. So without further ado, I welcome you, Dr. Calkins.
Great. Well, thank you very much. It's a great honor to be with you and to have a chance to share my thoughts about atrial fibrillation ablation. Let me just get my slides up. Hold on. Am I sharing my screen now, Raul?
Not yet.
Not yet.
Okay, hold on. Here we go. Share screen. Desktop. Share. Wait, I have to do something to set privacy and security. Hold on. We should have, let's see, privacy.
Suresh, can you help?
Unfortunately, it's on Dr. Calkins' screen that.
Hold on. Let's, oh, that's one little glitch. Hold on. So advanced.
Thank you.
Oh.
Dr. Calkins will be talking for about 40 minutes and include various case presentations. At that point, we'll introduce the panelists and start our discussion with more case presentations.
Let's see. So I'm, oh, John. So I've, yeah, let's see. Open system. Let me try a different computer and see if I can get it with that. Hold on a second.
Sure.
Okay, Raul, why don't you go ahead and start with case presentation?
Okay, so we're gonna flip the order if that's okay, Hugh. Is that
Yeah,
okay with
yeah.
you?
Flip the order with the case presentations and I'll try to figure out what the heck's going on here. As soon as I can share my screen,
Okay.
we'll be back in business.
First, I want to introduce the panel. I'm Raul Mitrani, Director of Cardiac Electrophysiology at the University of Miami Miller School of Medicine. I want to introduce Dr. Jeff Goldberger, who's stepping into the screen. He's Director of Cardiology at the University of Miami. Dr. Litsa Lambrakos, she's one of the cardiac electrophysiologists, Assistant Professor of Medicine at the University of Miami.
Hi,
Dr.
good
Alex.
evening, everyone.
Dr. Alex Velasquez. He's also one of our cardiac electrophysiologists, Assistant Professor of Medicine at the University of Miami. And then we have our two fellows who helped make this evening possible. There's Chaitra Mohan, one of our fellows, and Italo Novoa, one of our fellows. So were you able to
No, I'm
find your connection?
still trying to figure this thing out. So I'll keep working on it.
Okay, no problem. I'll go first. So the first presentation, do you all see my screen?
Yes.
Yeah, we can see.
Okay, it involves implantable loop monitoring post atrial fibrillation ablation. So as you all know, implantable loop monitors are an excellent way to detect atrial fibrillation. It was first developed to detect atrial fibrillation in patients with cryptogenic stroke, but it quickly evolved to include other indications, including monitoring for atrial fibrillation. Some of us use it to monitor for atrial fibrillation after ablation, if there's a clinical need to do so. So I'm presenting actually kind of a double pair, kind of the same principle. First one is a 65-year-old man with hypertension who had asymptomatic paroxysmal atrial fibrillation that transitioned to persistent atrial fibrillation. He had an implantable loop recorder placed to track his atrial fibrillation because at first he was asymptomatic. He wanted to know how much AFib he was having, so we placed the loop recorder. In February 2019, he had a successful pulmonary vein isolation, and we also found a premature atrial complex focus, which we thought was also a trigger, and we ablated that focus. He had early recurrence of atrial fibrillation that resolved spontaneously. This occurred a few weeks later. So
Is it now working?
You got it now.
You got it. Good.
Should I finish my case?
Whatever you want to do. Let's just make sure this. I'm in business. Do you want me just to go?
All right, I'll come back to my case later. Go ahead.
Okay, so anyhow, thank you. We're going to talk about catheter ablation of atrial fibrillation. My relationships with industry are shown here. So I'm going to give you sort of a high-level overview of Afib ablation. We'll talk about indications. We'll show some new data about first-line ablation. I'm going to make you aware of some of the new ablation energies coming down the pike, and then we'll draw things to conclusion. Let's start with two quick patients, a 62-year-old man with new onset paroxysmal AFib twice a week for 3 hours each time, no past medical history, and a normal EKG and echo. And the question is, what would you do for this patient? No treatment, toprol and flecainide, or catheter ablation. So you can ponder that as we go through the rest of the talk. And the second is a 75-year-old diagnosed with persistent AFib 2 years ago, put in anticoagulation, now having decreased exercise tolerance. He shows up with AFib with a rapid rate and a reduced EF in his echo. So for this 75-year-old, you could just bump up his toprol for better rate control, put him on amio and cardiovertin, do an Afib ablation, or ablate his node and put in a pacemaker. And we'll come back to that at the end of my presentation. Let me just make a few comments about catheter ablation of Afib in general. I think we all recognize, or certainly I recognize, the contributions of Michel Hasseguer and the group in Bordeaux, who in 1998 put this paper in the New England Journal of Medicine, making the point that Afib is triggered from the pulmonary veins. And prior to this paper, this was not recognized, I think, really at all. And this has paved the way for our current strategy for Afib ablation, where Afib ablation really focuses on the pulmonary veins. We use the comment, the cornerstone of AF ablation is pulmonary vein isolation. And shown in this slide is a CT scan of the left atrium with the 4 pulmonary veins and a lesion set created with RF ablation. This can also be accomplished with the Cryoballoon System. Now, this slide shows 2 patients. Each one, you see the CT scan above, then you see a baseline voltage map where purple means sort of alive, healthy tissue, and red is electrically silent. And this is pre and post an Afib ablation procedure with a Cryoballoon system. So you can see that everyone's atrium looks a little bit different. They can be big, they can be small. Pulmonary vein anatomy can vary, but the goal of the ablation procedure is to electrically isolate those veins, or on a CT scan, turn the voltage to red. Now, when we do this procedure, this addresses many of the triggers of AFib, whether the mechanism of AFib is poorly described. Is it reentry? Is it the ganglia play a role, shown in yellow in this slide? You have non-pulmonary vein triggers. You have small rotors, big rotors. The bottom line is, by isolating the veins, you address many mechanisms for AFib, and it seems to be effective in most patients. So today we can isolate the veins with point-by-point ablation or the Cryoballoon system. Both are excellent for this indication. I think where we really have a lot of unanswered questions is how to ablate persistent, long-standing persistent AFib. Do you ablate the posterior wall with lines? Do you ablate fractionated areas? Do you isolate the appendage? And you look for non-pulmonary vein triggers? There's lots of ideas and strategies that have been developed, but none have proved the test of time of showing that they really improve outcomes. So this is a hot area for research, and we need to do better to sort this out. Now, in terms of where we stand today with outcomes, this is what I think is really the right approach. If you think about single procedure outcomes in an optimal candidate for ablation, someone with paroxysmal AFib, otherwise healthy, not too many comorbidities, single procedure success, 60 to 80%. If they're a poor candidate, they've been in AFib for years, they're extremely obese, they have other comorbidities, success falls to the 35 to 50% range. And when we say success, we mean AFib free, at least based on symptoms, at 12 months out. Of those doing well at 12 months, there's further recurrences of AFib over the next period of time, with AFib coming back in about 1 in 4 by 5 years out. So we never say we cure AFib. It's like cancer in remission. The AFib is controlled, hopefully for a lifetime, but an ablation procedure or a drug may buy a patient 1, 2, 5, 10 years of sinus rhythm. Now, a study I really like when you think about AF ablation is the Circa Dose trial that Jason Andrade led. And this was a trial where they had patients with paroxysmal AFib. They put in an implantable monitor before the first procedure so they could precisely define success. They used both the cryoballoon and RF, and the results are shown here. So if you define success as freedom from any AFib after 3 months on this implantable monitor, regardless of symptoms, you can see the success rates are around 50 to 55%, the first graph. If you define success as freedom from symptomatic AFib, what patients care about, success rates on the right panel are about 79, 80%. But I think the most interesting thing is this study is if you look at AFib burden, the percent time patients are in AFib pre and post ablation, you can see in this slide, whether it's RF or cryo, and there are 2 different cryo arms, that the AFib burden reduces by about 99%. So I think the study tells us it's hard to get rid of every last minute of AFib in every patient, but AFib ablation is very effective at dramatically reducing AFib burden, which I think ultimately is one of the most important parameters and endpoints to consider. Now, a couple new things to make sure you're aware of, you're up to date. One, the ESC published their latest Afib guidelines earlier this year. They actually were published last fall. They really were the 2020 ESC Afib guidelines. There's really no big changes compared to their 2016 guidelines, but there's some other features that are worth being aware of. There's some beautiful figures. This is one of the figures from this document that looks at AFib-related outcomes: death, stroke, LV dysfunction, cognitive decline, depression, quality of life. And it summarizes how much AFib impacts each of these endpoints. And I think this is a very useful slide when you're talking about AFib to internists, family physicians, or patients, to sort of realize how important AFib is, not in terms of just quality of life, but all these other endpoints. So a beautiful figure in the ESC guidelines. They have another beautiful figure talking about risk factors for AFib, the big 4: age, genetics, male gender, and ethnicity. And then on the outer circle, all the other risk factors for AFib. Recently at the ACC this year, there's been a lot of new data stressing the importance of alcohol as a risk factor for AFib. Even a drink a day increases risk of AFib. Anyhow, another beautiful figure that the ESC brings to us that you may find a value when talking about AFib. They also have a new way of characterizing AFib. They want us all to think about the 4S Afib characterization approach. You first think about stroke risk, then symptom severity. Then you want to think about the severity of AFib burden, the percent time in AFib, like Dr. Andrade used as an endpoint. And then think about the substrate. Is this paroxysmal AFib in a small, healthy atrium? Or is this persistent AFib in a markedly dilated, scarred, fibrotic atrium? And that impacts our ability to be successful, also stroke risk. So again, a new way to sort of think through management of AFib. And finally, they have the ABC pathway. I think this document had lots of little gimmicks and things, but they're clever. Here, ABC, anticoagulation, avoid stroke. That's the most important thing to consider. B, better symptom management. Think about quality of life. And C, cardiovascular and comorbidity optimization. I think we all appreciate the importance of risk factor modification as you sort of address AFib management. And again, as another figure from the ESC guidelines, emphasizing the importance of risk factor modification, particularly weight, sleep apnea, and now alcohol. Another thing to be aware of is the EAST trial that was just published this past year in the New England Journal of Medicine, an extremely important landmark study where they took about 3,000 patients with early AFib that had other stroke risk factors. They randomized them to a rhythm control strategy or a rate control strategy. And most of the rhythm control was with antiarrhythmic drugs other than amiodarone. Catheter Bleish, this was not a catheter ablation trial. Catheter ablation was not performed in many patients in this trial. And the endpoint was cardiovascular death, stroke, or hospitalization for heart failure or acute coronary syndrome. Now, this study, the patients enrolled in this study are shown here. Those on rhythm control in the left panel shows the drugs that were used. You can see amiodarone was not used in many patients. It's mainly other antiarrhythmic drugs, catheter ablation in gray, 8% baseline, 19% at the end of the study. And again, in the patients with rate control, very little rhythm control therapies were used in these patients at baseline or even at the end of this study. So what did the study show? It showed it was a positive study that was terminated because they met their endpoint, as there was a statistical difference between these two arms. And this study showed that early rhythm control had benefits when you thought about the endpoint, again, of stroke, death, and other cardiovascular endpoints. So this was a positive study, basically making the case that rhythm control is superior to rate control in the management of AFib. Now, cynics would look at like this and say, how many patients do you have to treat to get one patient to save one life? It's not a massive difference, but it's a statistically important difference, and I think helps motivate a rhythm control strategy. This just shows each of the endpoints: death, stroke, hospitalization. And again, although each individual endpoint was not statistically, the treatment effect is shown here, that risk of death from cardiovascular cause was reduced, 0.72 reduction, stroke 0.65. Again, very significant reductions in each of these endpoints. So an important study to be aware of. Now let's move on and talk a little bit about some of the other developments. One is, for the first time, we have 2 catheter systems approved by the FDA for ablation of persistent AFib. We've been doing this for years, but now we have ablation systems that have met the FDA criteria to be approved for widespread clinical use and marketing. The first was the Cryoballoon System. This was a study I was involved with. Early persistent patients, less than 6 months of AFib, continuous AFib. It was a non-randomized trial with an objective performance criteria. And you can see the success rate was 55% with a cryoballoon, and the complication rate was virtually 0. There was only 1 cardiac tamponade in a patient having a redo ablation with RF energy in this trial. So very, very safe, reasonably effective, 55% success. Again, an important study that got this technology approved by the FDA. The other study was a study of the Biosense SmartTouch catheter. Success rates, are shown here, and you can see the primary efficacy was 62%. And then they looked at freedom from symptomatic AFib, which not surprisingly was somewhat superior. Again, this catheter also got approved by the FDA for ablation of persistent atrial fibrillation. So another thing to be aware of is another study that came out this year by Karl-Heinz Cook, which is a study showing that if you take patients with paroxysmal AFib, doing ablation will delay the progression to persistent AFib over time. And this study is shown here. Again, he took patients with paroxysmal AFib, randomized them to ablation or standard rate control. And if you look at over time, ablation resulted in fewer patients progressing to persistent AFib than the antiarrhythmic drug arm. They were actually randomized to antiarrhythmic drugs or ablation. Ablation was superior. So something else to be aware of. And then I also want to make the case and make you all aware of the growing body of data showing that ablating AFib and preventing AFib can reduce the risk of dementia. This is one study from the Korean National Health Service database looking at patients who had ablation versus medical therapy. This was not a prospective randomized trial, but it was a propensity match trial, making the case that there's sort of increasing evidence, not definitive, but soft evidence that controlling AFib with AF ablation may reduce risk of later developing dementia, an issue that most of my patients are very interested in and usually conclude that it's another compelling reason to think about AFib ablation. So the one of the points I was asked to address was the issue about initial therapy. If someone has AFib, should you try a drug or should you go straight to ablation? This year, we had 2 trials that addressed that question. First, let's just look at what the guidelines say. This is the 2017 consensus document. It says if you have symptomatic AFib that's paroxysmal and you failed a drug, it's a class 1 indication for catheter ablation. If you haven't failed a drug, first line ablation, 2A, you can do it, but a softer indication. With persistent, basically the same. With longstanding persistent, less data, they both get a 2B indication. And if we look at the ACC guidelines in ablation, they break it down into structural disease, not structural disease. Again, if you failed the drug, you get a solid line, a class 1 recommendation to go to ablation. If you haven't failed the drug, it's a 2A indication to go to ablation, a softer indication. So again, there's been 2 studies published recently in the New England Journal of Medicine looking at this question. The first led by Osama Wazni from the Cleveland Clinic. They took patients with paroxysmal AFib, randomized them to either cryoballoon ablation or drugs, and compared the outcomes. Cryoballoon ablation was far more effective, 75% versus 45% success. The nature of the complications are, again, slightly different between antiarrhythmic drugs or ablation, but the risks were low with ablation. So a very compelling study supporting the concept of early or first line ablation. A similar study was published by Jason Andrade. He used the endpoint of implantable monitors. So the success rates in both arms were somewhat less because they were looking harder for recurrences of AFib. But again, ablation was far more effective than antiarrhythmic drug therapy. Yet another study supporting early ablation. So what does this mean, at least in my opinion? Well, I think the data now supports first-line ablation. It does not mean that every patient should go straight to ablation and you shouldn't try drugs. I think it's important to realize that the types of complications you get with ablation are different than with drugs. With ablation, rarely you can get cardiac tamponade, rarely you can have a stroke, rarely you can injure the phrenic nerve, rarely you can have vascular injury requiring surgery, and rarely you can have an atrial esophageal fistula. That certainly, you don't see any of those things with antiarrhythmic drugs. So I think right now in a patient with paroxysmal symptomatic AFib, they have 2 options. They can do first line ablation that I think ultimately will get a class 1 indication, or they can try a drug, and if a drug doesn't work, then do ablation that also has a class 1 indication. It really comes down to their preferences and values. In my experience, some people hate meds and they like the idea of an ablation. Usually those are men. Other patients hate the thoughts of an invasive procedure, would much prefer to try a drug. In my experience, women are more likely to try the drugs first. But regardless, I think now we have data that both are very reasonable strategy, but you shouldn't oversell ablation as much as it's a very safe, effective procedure. So in closing, I want to just make you aware of a few new tools coming down the pike. So one new ablation system that's in clinical trials right now is the Adagio super cold cryo system. With standard cryoballoon ablation, we cool the balloon to about -40, -50 degrees. It's quite effective. With this new cryo system, you can go to -180 degrees, so you get deeper lesions. They protect the esophagus with a warming balloon. Preliminary results from this study look very encouraging. We'll have the answers in 2-3 years. So another tool for ablation of persistent AFib is sort of in development. And then I think you all have been made aware of this whole concept of electroporation. In the past with ablation, we've used thermal energy, heat with RF or cold with cryo. And now a new electrical energy source, electroporation, has been developed. This has been used for treating cancers and so forth in the past, and now it's being applied to ablation of AFib. You give high energy DC shocks, which basically poke holes selectively in myocytes compared to other tissue. Early data suggests that this type of non-thermal ablation is going to be safer, more effective, and a quicker procedure. There's several clinical trials launched looking at these tools, trying to get FDA approval. In 2-3 years, we'll have the answer, but certainly something to be aware of as you think about AFib ablation. So let's go back to the two patients. The first patient, early onset paroxysmal AFib with a normal EKG and echo. What are you going to do? Well, certainly you're going to treat this patient. I don't think toprol is likely to do much, so I think you really have the option of toprol and flecainide or first-line ablation, which is now supported by those two recent New England Journal of Medicine trials. Which you choose, again, I think depends on patient preferences and that discussion about preferences and values with the patient that's so important. The second patient was very different. This guy's been in AFib for 2 years. He has a rapid rate and a cardiomyopathy. Clearly, you want to do something to control his AFib. And the options we presented were better rate control. You certainly can make that argument. It's going to be hard to rhythm control this individual. You could just get his rate down. If you can't get it down with a beta blocker or DID, you could ablate the AV node. Another approach is get aggressive, bring him straight to the lab and do an ablation. The third approach, and what I would do in this patient, is put him on amiodarone as soon as I see him, cardiovert him in a month, and then in 2 months, when the next slot in the ablation lab opens up, bring him in for an ablation. Hopefully he will have been in sinus rhythm for a month or two. His atrium will be smaller. His risk of a stroke from the procedure will be smaller. Do an ablation then and ultimately get him off amiodarone 2 months later. I think there's very little risk to short-term amiodarone used this way, but certainly there's it's certainly going straight to ablation is reasonable if you got an open lab, and rate control alone wouldn't be wrong, but it wouldn't be my first choice. So I'm just going to conclude that catheter ablation is a safe, effective, and commonly performed procedure to treat AFib. New data supports the role of ablation for persistent AFib as well as first-line therapy. There's new data showing that AFib ablation slows progression of AFib to persistent AFib and prevents dementia. We got some new therapies coming down the pike, including supracold ablation and electroporation. And I will stop there, and I appreciate the invitation, and I apologize for the technical misstep when we got started. Thanks so much.
Thank you so much, Hugh. I mean, the outstanding presentation makes up for this technical snafu, but I just have a question on the last patient. Clearly he has a cardiomyopathy. Now there's evolving data to suggest that AFib ablation may actually improve mortality in patients with low EF and AFib. Can you comment on that?
Yes, we have Nasir Marouche did a Castle AF study where he looked at catheter ablation in patients with heart failure, in AFib, and showed a mortality benefit in that trial. It was a small study, not, had some limitations, but certainly was an important study. It was the first study to show a mortality benefit. And because of that, the new AHA-ACC guidelines give catheter ablation of AFib and heart failure patients a 2B indication. It wasn't a big definitive study, but it certainly was very encouraging. And certainly my experience is that catheter ablation is extremely valuable in the setting of heart failure. I'm not saying end stage heart failure, but in selected patients, I think it's a really terrific procedure. And I firmly believe, and I think you probably agree, that AFib is closely linked to heart failure. In that first slide from the ESC, one of the risks of AFib is heart failure. And I've seen loads of patients, despite good rate control, slip into heart failure from AFib. So I'm a firm believer in rhythm control, and your best effort, your best chance of getting rhythm control is to treat patients early. Once you've been stuck in AFib for 3 years or longer and have a big atrium, the horse has left the barn, and by then you can't change course later in the course of the disease.
So we look at left atrial volumes in someone with heart failure to try to adjudicate whether there's a reasonable chance. I mean, do you look at things like that, or moderate or severe mitral regurgitation?
Yeah, no, I think that left atrial size says it all. And whether it's with echo, but particularly with that CT scan where you get beautiful, volumes of the atrium. If you have this huge grapefruit size atrium, I don't care what you're going to do, you aren't going to get that patient back to sinus rhythm Whereas if you have a small preserved, atrium, I think that says a lot, and you're going to have a much more success in that patient. So I think whether you use, real careful echo imaging prior to ablation to sort of separate out the groups, or if you, when you do the ablation, look at the CT scan, and if it's a blown out atrium, if one procedure doesn't work, remember not to bring them back for a second procedure. There's different ways to look at it, but I agree. We've seen the same thing in Baltimore as you.
Now, I've done a similar strategy as you also, that I'll cardiovert someone on amiodarone, almost like a proof of concept, and maybe to shrink the atrium and then bring them back for an ablation. I think amiodarone is a great drug as a short-term drug, but I don't like having patients on amiodarone in the long-term if I can help it. But I don't know if there's any data to support that approach.
Well, there's some data from the Bordeaux group looking at restoration of sinus rhythm prior to ablation, showing a better short-term efficacy, but not, I don't know if it didn't translate into long-term efficacy differences, but there's some data to suggest it, but there's never been a big sort of definitive study looking at it. But I firmly adhere to that approach. I think it's the way to go. And if you put them on amiodarone, cardiovert them, and AFib comes back, then you have no option but to do the ablation. If it works, you have the option of doing the ablation, stopping the amiodarone, or getting them on a low dose of amiodarone, or transition them to a different antiarrhythmic.
I agree. I think Dr. Goldberger has a question.
So that was a great presentation, and it's really exciting time for AFib. So I'd like to ask you a question. You put up the original Hasegir slide and acknowledged the really groundbreaking findings that he had that really opened up the field, which we were lucky enough to be around for at the time. So my question for you is the following. What would you say is, in the last decade, the most significant change or advance that's been made in AFib ablation?
Oh, I mean, I think if you look at what's happened over the last decade, it's been lots and lots of small incremental improvements that together have improved most dramatically the safety of the procedure. I think the efficacy has improved as well, but I think the safety, and if you were to ask me the single most important switch, I'd say it's the practice of performing these procedures on uninterrupted anticoagulation and the dramatic reduction in stroke risk associated with AFib ablation. I think that has been the biggest and most important change. I mean, you and I both remember the days when you'd see strokes in 1 or 2% of patients, and now it's 1 in 500 with this uninterrupted NOAC or warfarin therapy. What a game changer that was. So I'd say that would be the number one change. I mean, other things, contact force sensing catheters for RF ablation were a big step forward. The second generation cryoballoon was a big step forward. Using ICE imaging to guide the transeptal, lower tamponade rates, temperature monitoring when you use RF, and being much more, lowering the power on the posterior wall. All these little changes have made, I think complication rates have gone from 7% to 1% over the last decade. So I think that's the biggest change. And there's been a lot of missteps. I mean, this whole cafe ablation, ablating all these fractionated areas. The group, I heard Piaget basically get up at a meeting last year, a year ago, basically saying that they have tremendous regret in the stepwise approach to AF ablation, where they were basically very aggressively ablating the sinus rhythm, and him describing these burned out, horrific atria they now are dealing with, basically saying we made a mistake. I think that was the biggest mea culpa I've ever seen in the field. But we quickly abandoned those sort of ablate the whole atrium approach, and that hasn't been our policy at Hopkins.
And I think we have similar philosophies here in Miami, and try to take a minimalist approach and do what's proven to work, and not do what's kind of out there. I think Dr. Velasquez has a question.
Well, thank you, Dr. Hopkins, for your insights on AFib as a disease process. Back to your ESC slide, where we looked at all the risk factors. One factor that I saw kind of missing, but it's becoming a increasing trend lately is heart failure preserved EF, and specifically within heart failure preserved EF, an increased awareness of amyloid disease. Have you incorporated a protocol in your practice to seek out or to screen patients for amyloid now that there's increasing therapies, or there's actually therapies coming out for amyloid that could alter the course of patients with AFib that could be potentially presenting as AFib as initial presentation?
So yeah, thank you for that question. I mean, yeah, this whole issue about HFpEF, my colleague Kavita Sharma is very interested in HFpEF, the heart failure group here. So they have a very big HFpEF program, and it's AFib is sort of one of even the diagnostic criteria for HFpEF. The overlap between AFib and HFpEF and obesity is extraordinary, and it's a terrible prognostic factor. The question is, does ablation change outcomes in HFpEF patients? I think there's a couple of early series showing some benefit, but we clearly need more studies looking at that. The issue of amyloid, I think, is a very good one. I know in EP, we don't see many HFpEF patients brought to the EP lab for AF ablation. I mean, usually they're really bad candidates in terms of their obesity and other comorbidities. So we haven't seen that many. So we haven't had our ears been looking out for amyloid, but I know our heart failure colleagues always think about that. But a good question, and I don't know the answer.
So let me ask you a question on the first patient. So this is the young guy who had relatively low risk factors, had initial AFib, and I agree he's a good candidate for ablation. Now, you and I and 99% of VPs, if someone comes in with a supraventricular tachycardia through the emergency room, I think the vast majority of us have no problem taking that patient to the lab on that index hospitalization, because we map the SVT and we can eradicate it with a success rate well over 90–95%, depending on the mechanism. Are we at the point that if a patient comes in with AFib for the first time, that we should take him right to the lab? Or what's your approach? Because I can tell you our approach is not to do that.
No, I mean, our approach is not to do that. I mean, one, we have a waiting list that's at least a month long. So even if they want to come to the lab, there's no room, for a 3-hour procedure to be added on. And two, I think that's a bit aggressive. I personally think for most of my patients, they try an antiarrhythmic drug first. If it doesn't work, we do an ablation, partly because they got to wait a month or two anyhow. So try an antiarrhythmic drug while they're waiting around. But I don't think this is not PSVT ablation. I mean, you and I are well aware of some horrific complications that can occur, whether it's gastroparesis or bronchial fistula or whatever. So certainly we're not at the point where they go in the emergency room and you bring them straight to the EP lab. I think that's overly aggressive, and I think it's an elective procedure. Also, in terms of stroke reduction, our practice is always to start a NOAC 3 weeks before ablation. And if they just show up in the emergency room, you don't know how long they've been in an AFib, they haven't been anticoagulated. It's just, you're asking for trouble bringing them right to the EP lab.
No, I agree. And I think we're also very big on risk factor modification. And one of our cases will highlight that. But I think we're looking at AFib more like coronary disease. It's not just coronary disease. You just don't put a stent and say everything's fine. You have to treat the underlying substrate. So we're big on ordering sleep studies if they're snoring or have obesity, on making sure their blood pressure is controlled, and trying to get them on a weight reduction program, get them to exercise. So I think it's a more comprehensive approach, which you can't do if you just take them to the lab right away. We've seen that in the community hospitals, that some patients are getting AFib ablations right off the bat. That's why I bring it up.
Yeah, I think we think like you guys are thinking, same approach.
Jeff, do you have any comments on the risk factor modification approach we take? You're muted.
Now, there we go. Yeah, I agree with Dr. Mitrani. I mean, I think we've been very impressed with the data on the risk factor modification and how much it actually can impact the outcomes of AFib ablation. So much so that we really formalized that into a program. We're seeing really some pretty dramatic results.
So Jeff, let me ask you a question. When you say you've developed it into a program, because it's easy to talk about, but hard to do, what is this program and how have you made it happen? Because in most places it's the sleep people aren't available, the weight loss people aren't available. What has your secret been?
So our secret, well, first of all, it's a nurse practitioner run program. So we have a nurse practitioner who's trained to really is focused on doing this. And, you know, at the initial meeting with the patients, there's actually a contract. So patient writes a contract with the nurse practitioner about what the goals are and what's going to happen. It does, I mean, there are difficulties. I mean, sometimes you need access to the sleep medicine people and the nutritionists and this and that. It does require a little bit of arm twisting to get all the things that the patient needs done. But, you know, I think when you have a coordinated program, you know, where you literally have to go through the checklist and you're focused on meeting endpoints. You know, they have targets for weight loss. You know, I think and then it also requires a motivated patient. We certainly have patients who are not motivated, but plenty of our patients are motivated.
So is this something when every time you see an AFib patient, you have that nurse practitioner seeing them with you, or you see them and then you send them later on to the nurse practitioner risk factor modification program if they have any vices to need a little correction? Yeah,
so yeah, it's basically that. I think it's as Raul mentioned. I mean, we explain to the patient that AFib it's like coronary disease. You wouldn't pop a stent into somebody and say, don't worry about what your cholesterol is, right? So we tell them the same thing. You can't just come in, have an AFib ablation and expect that, you know, you're going to be cured forever. You have to handle the risk factors. And I think the data is actually very good to suggest that if you, like you said, if you have a conversation with the patient and you say, these are important risk factors, go and take care of it, the chances that that's going to happen are very small. But if you do it within the context of care and clinical visits, you actually have greater success.
Yeah, that sounds really terrific. I salute you for making that happen. That's great.
Yeah, maybe, you know, we can share some data with you later because we're doing a clinical trial where we're comparing risk factor modification to risk factor modification plus liraglutide, which is a GLP-1 agonist used for weight loss.
One of our cases, we'll talk about that.
We'll talk about that, but actually in both groups, because we do a 3-month pre-treatment before they even get their ablation. And we see actually significant weight loss in both the risk factor modification group in 3 months and even greater weight loss in the risk factor modification plus liraglutide.
So another risk factor we see is alcohol, which I think is ubiquitous all over the world. You know, and I constantly have patients tell me, well, I thought you doctors said that having 1 or 2 glasses of red wine a day is healthy. But, you know, how much alcohol do you limit your patients?
Well, I mean, this year you have all the new data that's come out. The paper earlier this year in the New England Journal of Medicine saying that even a glass a day of alcohol increases your risk of AFib. And then the study that came out at the ACC basically making the same point. I mean, I tell them to, I mean, I think alcohol is a problem both because it can trigger AFib, but it also carries a lot of calories. So getting them to, you know, reduce or eliminate alcohol, I think is a worthwhile goal that not everyone's willing to do. So it just make them aware of it.
Right. I mean, I agree with you. I tell my patients, because they want a number, I tell them to try to limit it to 3 drinks a week and no more than 1 a night. I don't know if that's good, but I know that 1 drink a day does increase the risk of atrial fibrillation. So we have to stay below that threshold without asking them to totally abstain. Do you have them abstain right after an ablation?
Oh, I don't have them completely abstain. I just keep, limited. I mean, some people seem exquisitely sensitive to alcohol where that will always be the trigger. And for them, it's clear, just keep it up, at least till they're through the healing phase. Others, it seems to make less difference.
And the last thing before we move to
More
our
than,
cases.
sorry, I just wanted to comment on the alcohol because I do ask specific questions about that, and more, like I said, a lot of people underestimate how much they're actually drinking. So I do actually advise 3 to 5 drinks a week. And I ask you, and for a couple of reasons, one for the atrial fibrillation, but there's definitely data that says, even more than a couple drinks per week versus moderate amounts. There was some data, I believe, that shows distinct fibrillation. And then the other thing is, I think for women, really, for multi-organ effects, including the liver and, probably the heart, that the threshold should be lower. So I think that number 3 to 5 is probably good.
All right. So I think we'll move on to the cases. Let me see. Can you stop sharing?
Yeah, I'll stop sharing. Yeah.
So let me see. I'm not at the full. Here we go. All right. So just to remind you, especially for those who joined late, I started to present a case. This was a 65-year-old man who had a history of hypertension, had asymptomatic paroxysmal atrial fibrillation. As you can see in this slide, he transitioned to persistent atrial fibrillation. So this is a nice case of the natural history of atrial fibrillation, which Dr. Calkins talked about. Although his average rate was 60, he certainly would spike up to over 200 beats per minute when he's exercising. He was in good shape and really was totally asymptomatic. And I had to talk him into an ablation. I usually don't try to talk patients into an ablation, but I felt he was young and in pretty good shape. So we did the ablation in February of 2019, as you see here. Had a brief recurrence of AFib a few weeks later, and then nothing. So he's doing great. He's happy as a clam. And in retrospect, he says he feels better. So I think that's a point, that sometimes patients who are quote unquote asymptomatic with their AFib just kind of got used to it and accommodated to the atrial fibrillation, because once they get into sinus rhythm, they'll come back and say, oh, I feel better. And you're thinking, well, you told me you didn't feel anything before. Now you feel better. So that's great. So the question to the panel is, what do you do with this anticoagulation? You have a monitor here that's telling you no AFib.
So anyhow, if you look at the consensus document, it's very clear that your decision, everyone needs to be anticoagulated for 2 months after the ablation. And at that point, the decision should be based on their stroke risk profile and not on the perceived success or failure of the procedure. So, if it's Chad's Velasquez, if he's a man 2 or higher, I would generally recommend that they continue the anticoagulation, even if they're AFib free. But I think increasingly we're getting more and more data. We now recognize that Afib burden is a risk factor for AFib. Less AFib means less stroke risk. Is if you have a no AFib, is that a low enough of a stroke risk to stop the anticoagulation? We just don't have the answer to that. So for patients that are willing, that really want to stop the anticoagulation, that are willing to accept an unknown increased risk of stroke by stopping it, I say either if you have an implantable monitor, an agreement that if AFib occurs, we'll restart it. If they don't, they can check their pulse every day or get a live core monitor. But I clearly document that my recommendation was to stay on it. There's been more and more lawsuits these days about someone stopped anticoagulation, the patient has a stroke, and now they're suing everybody. So I clearly follow the guidelines as far as my recommendations, but patients may elect to stop anticoagulation, but it's somewhat at their own risk.
Any other comments or view from our panelists?
So, yeah, I mean, I agree with Dr. Calkins in terms of the lack of data. And I think that's really an important area for the future, because I think there's no question that there is a spectrum of risk, and people who are at the lowest part of the risk spectrum, it probably doesn't matter whether they do or they don't have AFib, and that's why we don't anticoagulate patients who have very low CHA2DS2-VASc scores. People who are at the high end of the risk spectrum, it also probably doesn't matter whether they do or don't have AFib, because they're still at risk. And it's really the people in the middle where you have to consider what their substrate is, and what their Afib burden is, and they probably interact to generate your stroke risk. The problem is we don't know how to exactly figure out which patients do and don't need anticoagulation in that group, and that's really the challenge.
I mean, I think we're all looking forward to Rod Passman, as you know, has been working hard to try to design a pill in the pocket anticoagulation study. Whereas if you have AFib, you're on anticoagulation. And yeah, it's going to be a prospective randomized trial, and hopefully the NIH has funded it, or hopefully they're going to fund it soon, because I think that's going to be really impactful, and I can't wait to see the results, but it's going to be 5 years away before we know what it shows.
So I don't think the CHA2DS2-VASc score says everything, and I think the ones in the middle, it's really lacking in terms of predictive power, right? A CHA2DS2-VASc score of 2 predicts a 2.2% annual risk of stroke. So especially after an Afib ablation. So one option, if they can't be on anticoagulation, of course, is to consider left atrial appendage occlusion. But here we're talking about patients who are atrial fibrillation free. What I've done is, for patients who have CHA2DS2-VASc scores of 2 or 3, I have a discussion with them. I do kind of say, if they leave it up to me, I'm going to have to continue anticoagulation. But many of them are interested in coming off anticoagulation, and I either implant a loop, or now I'm using the Apple Watch to monitor them, because it can monitor them even passively, right, with their algorithms. And let me show you another case along those lines. A 55-year-old man with history of persistent AFib, obesity, hypertension, prediabetes, and tachycardia-induced cardiomyopathy. 5 years earlier, he had PVI for AFib. He had no recurrence of AFib clinically after 2 years, and he wanted to come off anticoagulation. His EF completely recovered. Ambulatory monitors, no AFib. A loop recorder was placed, and after 6 months of loop recorded monitoring, anticoagulation was discontinued. So what is this patient's CHA2DS2-VASc score? Let's see. He has hypertension, that's 1. But does the prediabetes count as a risk score? I mean, I don't think so. And what about the tachycardia-induced cardiomyopathy? Cardiomyopathy counts, but his EF now improved. I mean, what does the panelists think his CHA2DS2-VASc score is? Is it 1? Is it 2? Is it 3?
No, I agree with you. I mean, I think if the guy's blood pressure is well controlled, if his EF is normal, left atrium small, I think this is someone, that I would call CHA2DS2-VASc 1, where, the CHA2DS2-VASc 1 patients, absolutely, you can stop anticoagulation in this setting. So I think your point's well taken.
So
Here, that
right.
would be concerning to me, just the history of the persistent AFib, and then the fact that, yes, it was a tachycardia-induced cardiomyopathy, but does that mean that, again, does this point to a substrate of susceptibility, which would... So technically, the CHA2DS2-VASc is low here. We're looking at a couple of just something in the clinical history that, may substrate-wise.
No, I think, listen, I think it's critical to listen to the patients. And I think some patients are definitely afraid of a stroke, and the idea of being on a NOAC doesn't bother them a bit. And other people just can't stand being on a NOAC, and they really are motivated to come off. And I think that really colors what approach you end up using in these sort of borderline cases that don't really fit the guidelines. But your point about if you have a history of tachycardia-induced cardiomyopathy, you're much more susceptible to have it come back if AFib occurs, I think is a very important point to remember.
Well, the other thing is patients who recover technically have what they call heart failure with improved ejection fraction. And some studies suggest that even though the heart recovers grossly, macroscopically, the EF is normal, all the walls move, there may be some subtle areas of fibrosis, and how this impacts AFib and stroke risk is really unknown. So, well, I agree, you can say it's CHA2DS2-VASc score is 1. I think if they've had a history of cardiomyopathy, you can also argue his CHA2DS2-VASc score is 2, right? Because if they have hypertension and they're completely well treated, we don't remove that as one of the risk factors.
Correct.
So, so now 5 years later, he comes back with an episode of AFib that lasted about an hour and a half. And here it is. So now what? So this points to what you said, that, AFib is not a cure. This is a progressive disease, but he did great for 5 years.
Well, I mean, this episode would certainly motivate you to put him back on at least for a period of time. And the question is, are you going to stop it again? I mean, the other point that Greg Lipp likes to keep making is that over time, you constantly have to reassess patients' CHA2DS2-VASc score, because as the time goes by, their age goes up and they can pass different thresholds where risk increases, or they can get diabetes or whatever. So this guy, by the time he had this recurrence, he's older. Now he's had a recurrence. Clearly, you're going to put him back on for a period of time. But I think it's all about this discussion to tell him, oh, you can stop anticoagulation, there's no risk of stroke, is obviously completely false. It comes down to these preferences. And, we live in this litigious society, unfortunately, where you really have to document your discussions and why you ended up doing what you did.
So this brings up a scenario that you encounter with the CHA2DS2-VASc scoring system, where a patient has a CHA2DS2-VASc of 1 for hypertension and they're 64. So they're about to age in, and their birthday is 2 months away. Do you wait 2 months to start anticoagulation? And in my mind, the concept is, risk is actually a variable. It's a dynamic process. It's not a discrete, discrete factor. So, I lean towards starting them early because I know that they're approaching that risk where we would want to anticoagulate.
Yeah, I mean, your point is perfect. It's not that on your 65th birthday, that day, your risk suddenly jumps up. It's obviously a gradual thing. So for patients that are whatever, 64, almost 65, 74, almost 75, I too dish out a lot of anticoagulants. That's for sure.
So anyway, I agree. The patient's very annoyed at me because I made him start anticoagulation again. And he has 1 or 2 episodes a year. But I mean, I don't know Dr. Passman well. I heard him talk, but wouldn't he say if your burden is so low, you don't really need anticoagulation, or he makes some type of point like that?
Well, I mean, his protocol is you get anticoagulated, I think, for at least a month after each episode. So that episode would have triggered a NOAC for a month, and then you'd come off it again if you're in the treatment arm. Yeah,
that's correct. It's intermittent anticoagulation. I mean, I think it's important also just to point out that although we currently are using the CHA2DS2-VASc score to stratify risk, overall, it's a very poor risk score. It has a C statistic of only about 0.6, which means it's only marginally better than a coin toss in terms of its predictive value. And I think that there are probably going to be some better, more physiologically based tests in the future that be used to assess stroke risk. And that gets back into the issue of how you diagnose atrial myopathy or cardiopathy, and how much that plays the role in terms of stroke risk.
this sort of brings up that new ESC 4S where they're sort of encouraging a characterization of the substrate, just as you're saying.
Yes. So
All
I
right,
think we're going to do better in the future.
I hope so. I hope so. A lot of patients are really annoyed at us when they come with their bruises. And of course, if they have a significant reason to come off anticoagulation and they need stroke prevention, occlusion of the left atrial appendage is an option. So we're going to move on to the next case, Chaitra Mohan. Are you ready?
Yes, I'm ready. Let me share my screen. Okay. Good evening. So my name is Chaitra Mohan. I'm one of the electrophysiology fellows here at the University of Miami at Jackson Memorial. Thank you all for joining us this evening, and a special thank you to Dr. Calkins for your time. So today I'll be presenting a case. So this is a case of a 54-year-old woman with a history of significant for persistent atrial fibrillation with a CHA2DS2-VASc score of 3, morbid obesity, hypertension, and type 2 diabetes. She's a participant of the LEAF study, which I will go into in just a few minutes. Her echocardiogram showed a normal LV function. She had a mildly dilated left atrium with a left atrium volume index of 37.4. So I just wanted to take a moment to talk about the LEAF study. Dr. Goldberger already touched on this a bit earlier. So this is a study based from here in the University of Miami by Dr. Goldberger, who's a principal investigator. And the background of the LEAF study is that epicardial adipose tissue may play an independent role in recurrence of atrial fibrillation after ablation. The ARREST-AF study showed that aggressive risk factor modification dramatically improved the long-term success of Afib ablation. Liraglutide is a glucagon-like peptide 1 analog, which we know reduces the epicardial adipose tissue thickness. The hypothesis of the LEAF study is that this left atrial epicardial adipose tissue reduction can have significant beneficial effects on the underlying atrial substrate, and that treatment with liraglutide will significantly reduce the left atrial epicardial adipose tissue and consequently stabilize the substrate for atrial fibrillation. The primary endpoint of this study was that the change in left atrial epicardial adipose tissue after 3 months of risk factor modification versus risk factor modification plus liraglutide, which is assessed by CT scans. So the study design of the LEAF study, so there were 2 groups, 30 participants each. So 30 participants were in the risk factor modification group alone, and 30 participants in the risk factor modification plus treatment with liraglutide. The study began 3 months prior to ablation and continued for 6 months after ablation. The participants also underwent 2 CT scans, which were performed during the 3-month lead-in period to assess the amount of left atrial epicardial fat. So for our particular patient that I'm discussing, she was in the risk factor modification plus the liraglutide group. And this graph depicts the data of the percent change of BMI from the time the patient entered the study, which is represented here by -3, for a total of 3 months until she underwent ablation at time 0. And we can see here that the percent change of BMI from the baseline until her time of ablation was around -6%. And this graph here represents the percent change of left atrial and total epicardial adipose tissue volume for our patient 3 months after receiving the liraglutide therapy. And so we can see here that she had a 16% decrease of left atrial epicardial fat and a total of 25% decrease in the total epicardial fat. The patient subsequently underwent catheter ablation. So she underwent the left panel is a voltage map of the left atrium, and which is post cryoballoon ablation for pulmonary vein isolation, as well as additional RF lesions of the right pulmonary vein antrum and the left inferior pulmonary vein ridge to complete isolation. The patient also had documented typical atrial flutter. So the right panel is a local activation timing map of the right atrium post radiofrequency ablation of the cavo-tricuspid isthmus. The follow-up for our patient in the 18-month follow-up, that since then the patient was discontinued on amiodarone 6 months post-procedure. She remains in sinus rhythm, and the total amount of weight loss that she's experienced has been 22 pounds. And she has had no further recurrence of atrial fibrillation. So I think at this time, either Dr. Mitrani or Dr. Goldberger, if you wanted to comment more on the LEAF study. I just touched on it a bit.
Go ahead, Jeff.
Yeah, Chaitra, thank you for that wonderful presentation. And I would just reiterate what we saw, or what I said earlier, is that we're actually seeing very nice weight loss, whether the patient, whichever arm the patient is in, whether they're in the risk factor modification or the risk factor modification plus the ragglitide. I think it really is a testament to the value of having a provider deliver that kind of care to the patient. The whole hypothesis about the epicardial adipose tissue and its importance in atrial fibrillation, both in incident atrial fibrillation and also outcomes after catheter ablation. I mean, all the studies to date are really associative. So there are, you can look at Framingham study, and there's a correlation between epicardial adipose tissue and incident atrial fibrillation. There are a lot of studies, mostly from Asia, that have looked at recurrence of atrial fibrillation after catheter ablation in relation to epicardial adipose tissue. And it's also a fairly strong predictor. But there's nobody that's really done a targeted study to look at the therapeutic benefit of reducing epicardial fat in atrial fibrillation and seeing if that can improve outcomes in atrial fibrillation. Again, harking back to our analogy of coronary disease, where we treat patients with coronary disease with statins to prevent further events. It's quite possible that for atrial fibrillation, if the hypothesis is correct, if the epicardial adipose tissue is a pathophysiologic determinant of the substrate for AFib, that directly treating it can actually prevent further events. And there are some data that suggest that certain genes are turned on in the epicardial adipose tissue that activate fibrosis pathways and inflammation pathways. So it is a very plausible hypothesis. We have another study that's actually going to be sampling epicardial adipose tissue in patients undergoing surgery to specifically look at some of the activation of some of those pathways. So I think it's a potentially exciting new therapeutic approach to patients with atrial fibrillation.
Just a comment on this patient, because I was very impressed. She's my patient. She weighed about 290 pounds or 135 kilograms. She actually had persistent AFib probably for 2 or 3 years. We first cardioverted her, tried an antiarrhythmic drug, didn't work, and then she went back into AFib. And then she enrolled in this trial. I think regardless of this trial, when patients are that morbidly obese, when they're more than about 140 kilograms or 300 pounds, I always ask them to lose weight regardless. I just think it's a safer procedure if they lose a little bit of weight. And by losing weight, it's more likely to make the procedure more effective. I mean, is there a certain weight you use? I'm asking to the panelists as a cutoff that you're not going to go beyond a certain weight to do an ablation, just because the risk may be a little bit higher, vascular risk may be higher. If God forbid there's a pericardial complication. The pericarditis may be more difficult. So what are your
Well,
thoughts?
I mean, I think the data out there, there's a number of studies. We actually put together our data of obese versus not obese patients. And it's remarkable how our hypothesis was that the complication rate was going to be higher in the obese patient. That really wasn't the case. I think where the difference is I think the recurrence rate's higher in the obese patients. I think all these studies on late recurrence shows that the obese patients have more late recurrence. But even really obese patients, you get them through the study. There's only one patient for me that was too much, is I got him on the table, stepped on the floor, and I couldn't see the heart. And I think that was a sign that this patient, who weighed in a little over 400 pounds, was a little too big for an ablation. So I took him off and told him I can't help him. The other problem with weight, which is important, is that weight increases how much radiation exposure you get during ablation fairly dramatically. In the cases I've seen of radiation-induced, skin lesions and ulcers and whatever else, are usually obese patients who've got multiple redo procedures with long fluoro times. It's a real concern. So I agree with you. I tell everyone to lose weight, but making it happen is a different story. But what a nice study. I congratulate all of you. I really look forward to seeing the results. Beautiful.
Let me just a housekeeping item for our audience. If you have any questions, please feel free to use the chat function, and either we'll answer them directly. One of the panelists will answer them on the chat, or we'll bring it forward to the panelists. Any other comments on this case? I mean, I think the LEAF study is going well, as Dr. Goldberger said, for both groups. It's kind of fascinating that this one drug reduces epicardial fat so much.
In your study, are you taking all types of AFib? Are you limited to paroxysmal? Or are you sub-randomizing persistence to two different arms? Or how'd you design it to address that?
So the study was originally designed to be for persistent AFib, but with COVID and slow enrollment, we had to expand it to basically include paroxysmal AFib patients as well, who are obese. You have to have, it has to be patients who want to have a catheter ablation procedure, and they have to be more than 27 kilograms per meter squared.
So that should be a lot of patients, at least here in Baltimore.
Yeah, there's plenty of those patients.
All right, we have a very interesting case by Dr. Velasquez coming up. Alex, you're muted.
Yes. All right, so let me just screen share my slides. All right, can you see my slides?
Yes.
All right, very good. All right. So I don't have any disclosures. I'll start off with my patient was an 84-year-old man with congenital partial absence of a pericardium with a posterior cardiac rotation. So a year ago in pre-pandemic, he was transferred to our hospital for an advanced heart failure evaluation. He had a prior dual chamber pacemaker implanted for tachycardia bradycardia syndrome. He had a remote history of AFib, as I understood it. And after hemodynamic stabilization in the CCU, our service was called to evaluate him for possible cardiac resynchronization therapy. He was dyspneic at rest at that point. Even just talking to him, he had interrupted speech, and I think he was even delirious from his low flow state. He had trouble with recall at that time. His ejection fraction at that time was 10 to 15%. And this was his baseline EKG. I'm just going to open it up to the panel just to, think what kind of block, is this an appropriate candidate for CRT? Is this someone you would consider?
Well, he certainly seems to have runs of atrial tachycardia with a rapid rate. And then his conduction block seems to be sort of a non-specific ICD, not really a left bundle that you would you would think about using a CRT for. So I mean, it's one thing if you're going to ablate the AV node and put in a pacemaker for AFib with rapid rate, but I wouldn't run to CRT for this guy.
Anyone else? Okay, so yeah, so my initial impression was, forget about it. What am I doing here? But then I realized, digging further into his case, that his particular anatomy may have actually been a favorable candidate, and even though it didn't look like a left bundle, his heart was so rotated that his septum was actually lateral to his lateral wall. And in his New York Heart 4 state, I thought it might be reasonable as a palliative measure to implement CRT. So we did, and this is what his venogram looked like in the AP projection. Basically, the coronary sinus projects, basically to the right side, which is opposite where we usually expect it. And this is his final implant X-ray. So you see that the LV lead in position, and this is his post-op EKG, which I wouldn't wouldn't be glaring as an extreme success, but his QRS narrowed about 20 milliseconds. And more importantly, clinically, he was discharged from the hospital with New York Heart 2 symptoms. His atrial ectopy improved dramatically. As you can see, based on the chart, his pacing interrogations, his biventricular pacing was not impacted severely by the atrial ectopy, and he was able to walk up to 2 miles a day through the summer of 2020 during the pandemic. However, at the end of the year, and by January, he developed persistent atrial fibrillation. His biventricular pacing decreased down to 20%, and so he lost all benefit from the BiV. Due to the pandemic, he was resistant to come in to be evaluated and treated as an inpatient. So we started amiodarone in the hopes that medical therapy could change the course of the atrial fibrillation. However, he continued to be in atrial fibrillation, and he just progressively declined to the point where he developed decompensated heart failure. Ultimately, was transferred from where he was. He's across the state. And he was transferred at the point of basically cardiogenic shock. And a cardioversion at that point restored sinus rhythm and allowed for CRT. However, on inotropic therapy with Mitrani, he had recurrence of atrial fibrillation within 2 days. So at this point, I open up to panel as to what kind of rhythm or rate control strategies would we think about for a man as this, who clearly stood to benefit from CRT, but in his severe state, rhythm control strategy may be difficult.
Well, I mean, obviously your options are ablating his node would be one reasonable option. I think what most people would do, but I suspect you're going to tell us you ablated his AFib, and it's even a better option if it works. I would think most, at least we would consider this guy sort of too sick for an AFib ablation, but down there, you guys have a different view of the world. You probably did it, and it probably was a home run. So tell us.
Yeah, so no, we didn't think he was a very good candidate. In fact, at that point, due to his cardiogenic shock, his liver function was severely impacted. So his renal function was severely impacted. So we actually went forward with an AV nodal ablation. And we tend to, in our practice, we tend to shy away from AV nodal ablation as the nuclear option. But for this particular case, we went after it. Now, because of his anatomy, because of his anatomical considerations, even an AV nodal ablation was a challenge. So I can't imagine what an AFib ablation in this man would be like. Just to give you an idea, as an electrophysiologist, we're familiar with the cardio maps. But here you can see the depiction of the patient's face, and it's turned away from us. And this projection or this reconstruction with cardo sound is basically reoriented to resemble the LAO projection with the mitral valve on the right, the tricuspid valve over here on the left, and the aortic valve in between. And so clearly his anatomy was very distorted. Fluoroscopy would have been impossible to use to find the His. Even just the regular electroanatomical mapping system to create shells within the cardiac chambers was not useful. As you can see, I created a shell here depicted in green, and it was only partially representing the cardiac chambers. It was only through use of intracardiac echo and the implementation of the normal relationships of different structures, specifically the aortic valve and the tricuspid valve, that we were able to mark with the intracardiac ultrasound that usual location of the His bundle, and then based on the ICE mark, guide the ablation catheter to that point and then find the signal. So this is again the small His signal that we saw on the catheter right before we ablated. We turned on ablation for 30 seconds and the AV node was gone. So anyway, we did an AV node ablation and he had complete biventricular pacing afterwards. He had no, ventricular ectopy to interfere with IV pacing at that point. But in a case like this, knowing some data that we've collected over the years about PVI versus AV node ablation versus and biventricular pacing, there seems to be a signal that, at least by surrogate markers in the PABA CHF trial, that there's improvement of the outcomes if you do PVI over AV node ablation and IV pacing. And then as Dr. Calkins highlighted, there is a trial with the Castle HF where we know that PVI, or that we've seen that PVI has a benefit for patients with heart failure in terms of death and rehospitalization. And so last question that I have for the audience or for the group is basically, in this case where we were able to use AV node ablation, he was able to be discharged home and is now at home with IV pacing. Would pulmonary vein isolation offer an incremental value for a patient with this degree of heart failure and severity?
Well, I think the answer is we just don't know. I don't think the Castle AF enrolled sick patients like this, particularly with a screwed up anatomy. I'd be happy with the AV node ablation and not try to be a hero and try to do something rather overly aggressive in my mind, but that would be my perspective.
I agree. I think it's a great case. I think in the 1990s, there was too much AV node ablation. I'm still dealing with some of that, patients with like multiple pacer procedures and pacer-induced cardiomyopathy needing CRT. But I think nowadays, most of us shy away from AV node ablations, but in this case, you had no choice. I think in terms of doing further ablation, it depends how stable is he? Is he heading for a transplant? How big is his atrium? As you mentioned, his anatomy is so rotated, it would be most challenging to do an ablation. If his atrium is huge, I don't think it would be much benefit.
I also agree that I hate doing AV node ablations. It just feels really terrible to do it, and limited to elderly patients who are in AFib or flutter incessantly all the time that have failed one or more catheter ablation procedures. I think in paroxysmal AFib patients, when I have done it, I oftentimes regret it. And so we perform very few AV node ablations. I agree with your hesitancy.
Yeah, I think that's true. I think I think everybody appropriately shies away from doing it. When you do find the right patient though, it can be really a life-changing procedure. right? I mean, for the elderly patients who have multiple hospitalizations for AFib with rapid ventricular response, and they're completely unresponsive to antiarrhythmic drugs, and they're not appropriate for AFib ablation. I mean, you can actually make those people dramatically better. But again, it's very, very few.
Yeah.
And that's why we don't.
And
do
it's sort of like the last step of the journey.
Yes, 100%.
Yeah, yeah, I call it the nuclear option for that reason.
All right. Before we go on to the next case, we have a question from the audience. They are asking about the strategy of intermittent anticoagulation. Is this a valid strategy? Is this something that should, that people should be doing? Or is this something very limited to clinical studies?
Well, I mean, I personally think it's pretty limited to clinical studies. That said, if I have a patient, even if they're CHADS VAS 0 or 1, if when they go into AFib, they start a NOAC, then if you don't cardioverse for 2 or 3 days, you feel more comfortable not doing the TEE. So, I mean, there's plenty of patients I say, if you go back into AFib, start a NOAC, call me, we'll try to get you in for cardioversion within 2 days, even if their CHADS VAS score is low. So, but in the high stroke risk patient, I don't think it's a proven option now that you should recommend. It's more of a bailout strategy for someone who's willing to take an unknown risk. Once you've really documented it very carefully, you had this big discussion.
No, I agree. I don't think that strategy of intermittent anticoagulation is ready for prime time yet. But I have the opposite issue. I have some of my patients, they want to go skiing or do some dangerous activity. If they have kind of a borderline CHAD VAS score, I may have them hold.
I do this. I do the same thing. Patients are going, oh yeah, I think that's not unreasonable. I mean, this concept about rebound, I think, has been proven not to be the case. It's not that you stop a NOAC and your blood becomes sticky. You just don't have anticoagulation. But in borderline risk patient, it's fine.
All right, so we're going to move on to the next case. Dr. Italo Novoa, our senior fellow, will be presenting a couple of cases.
Good evening, everyone. I'm Italo Novoa. I'm a electrophysiology fellow. Thanks, everyone, for joining us. Thanks, Dr. Calkins, for joining us to this conference. This is a 59-year-old male with ischemic cardiomyopathy, NMI in 2000, requiring bypass surgery, had a dual chamber ICD last generation in 2018. He had AFib, paroxysmal AFib in 2016, and underwent PBI and another outside institution. The report available to us say that there was low voltage in the posterior wall, and the EF improved slightly to 40%, and he stayed on amiodarone for 3 years. So in 2021, a few months ago, he had fatigue and dyspnea exertion, and there was evidence of AFib on the ICD. The guy was predominantly ventricular paced now, and the underlying rhythm was AFib with a very low response. So the left atrium was enlarged, very enlarged. The systolic dimensions 6.3 by 7.8, and the EF 35%. So we decided to do this procedure using a Carter system to map, to create segments on the right atrium and left atrium under this protocol that we have here, the electron morphology recurrence. I'm going to pass the word to Dr. Goldberger, so we have some slides about this trial. Yeah, Dr. Goldberger, go ahead.
Okay, so I'm going to just very briefly describe to you the electrogram morphology recurrence mapping that we have developed and that we use to try to understand what the drivers are for atrial fibrillation. One of the challenges for us in the electrophysiology laboratory, certainly for patients with regular PSVT, where on a beat by beat basis, the tachycardia is always the same. We can do time-based mapping because we can move our catheter around to different parts of the heart and measure activation times. And it doesn't matter whether you measure it on the 5th beat or the 10th beat or the 15th beat or the 20th beat, the tachycardia is always the same. But in atrial fibrillation, we know that's not the same. You go to the next slide. So that's basically the description here. So what we decided to do is to, instead of using activation time to map the arrhythmia, we are going to actually look at the morphology of the electrogram. And the concept behind looking at the morphology of the electrogram is that if you're very close to a driver, the activation direction is going to be very reproducible. And it's going to give you an electrogram morphology that's more or less reproducible. Whereas if you're far away from the driver for atrial fibrillation, it's going to hit the electrodes in multiple different directions. And in every direction that it hits is going to give you a different electrogram morphology. So next slide. So you can see here 2 examples of electrograms from patient with atrial fibrillation. In the top example, you can see that the obviously you have an irregular rate, but you also see that the electrograms themselves are very different from one beat to the next. Whereas in the bottom panel, you still have a very irregular activation, but you can see that the electrograms themselves are very repetitive. And we didn't really have a good way, you could actually look at this and you could see that, but there was no real good way to actually quantify this. So that's what we developed is a method to quantify the reproducibility of the electrograms, how much each electrogram looks like every other electrogram. Next slide. And basically how that's done is basically just a simple cross-correlation algorithm to see how much overlap there is between one electrogram and another. So on this cross-correlation table, you see 6 electrograms. So each electrogram in the x-axis is also shown on the y-axis. And we just do a cross-correlation of one electrogram to the other. So if you look, for example, at electrogram 2 at the bottom on the x-axis, you can see it doesn't look very much like electrogram 1, and so the cross-correlation is 0.24. If you go up to the next panel, obviously it has perfect cross-correlation to itself, so you get a value of 1. But then go up to electrogram 4, 2 and 4 look very similar, and you get a very high cross-correlation number. So you can do this for a 10 or 15 second period of AFib. You can identify each electrogram and then build a matrix of these cross correlations. And that's shown in the next slide. So here we have 300 or so activations. And now what we've done is we've color coded the cross correlation. So red means that there's near perfect cross correlation. And the color spectrum goes down to yellow, green, and blue. And it turns out that if you look at any electrogram reporting, it's going to give you a recurrence plot like this that's actually very characteristic for that site. Next. So we, based on this recurrence plot, we can actually calculate 2 different kinds of variables. One is the recurrence index, which is just the percentage of activations having the most common morphology. So you just find out what is the most common morphology, and then you actually just count and see how many activations have that morphology. So we also wanted to get some sort of estimation of how fast that morphology is. And that's basically captured in the next variable, which is the recurrence cycle length, or what we call the CLR. And that's the average cycle length between the activations with the most common morphology. So how fast is that one driver or that one electrogram going through the recording? Next slide. So this basically just summarizes the procedures that how we do this in the electrophysiology laboratory. We use a multi-electrode catheter. It really can be any kind of multi-electrode catheter to record 15 seconds of bipolar electrograms. And we do this in multiple sites. Patients have to be in atrial fibrillation at the time, otherwise you can't really calculate this. And we do this both in the left atrium and the right atrium. We're able to actually link the location either with Navix or Cardo with our custom-made system to actually do these calculations. And then we're these are the locations that we've been particularly interested in looking at. In the right atrium, we classify different sites, and in the left atrium, sites that have been also looked at as potential drivers for atrial fibrillation. Next slide. So you can go to the next slide. So go ahead, Italo.
Yeah, for these patients, as Dr. Goldberger was mentioning, so the goal is to find the areas of the heart that has the shortest cycle length and the one that is more frequent, so the highest recurrence also, the percentage of recurrence. So we see here in the left panel, you see SVC, IVC, superior vena cava, inferior vena cava, right atrial appendage, coronary sinus, septal right atrium, and other areas of the right atrium. And in the right side, you see the cycle length of the sample, as we sample like 15 seconds of Afib, and you see the cycle length, the recurrent percentage that we want to be highest. 100% should be perfect. And the cycle length recurrence that we want, obviously, is the shortest one. So you see here, we have to take a look at the recurrence percentage, and this here, the CLR. That's in this case is 2.7. So in the right atrium, so the shortest cycle length was 175 milliseconds here, while the cycle length 153, and the recurrence is not 100%, but it's 88%. So the best combination, we think that was this one, the septal right atrium, and the definition of the maybe a definition of the driver of Afib. So we can find another one, another driver that is by our definition within 5 milliseconds from the other one, but actually this is the best one that we have, 175. Maybe the other one, it's more than 10 milliseconds actually. So we consider from the right atrium that this area, the septal right atrium, is possibly the driver of one of the drivers. So it's because it combines the best recurrence percentage and the cycle length. In the left side, we found a few areas actually. We divided the left atrium and left pulmonary vein, right pulmonary vein, posterior left atrium, septal, and other areas of the left atrium and the left atrial appendage. So here you see that in the septal left atrium has one of the highest recurrence percentage, and the cycle length is one of the shortest, so 190. The left pulmonary vein also, well, actually that is the one that has the shortest cycle length. But the left atrial appendage is also another spot. So we consider that from the left atrium, the left pulmonary vein, the superior pulmonary vein actually, the left atrial appendage and the septal left atrium had the best combination of recurrence, morphology, and the shortest cycle length. So, and we pointed out those areas for targets for ablation. I don't know if you have any other comment, Dr. Goldberger, about this before we go to the next section.
No, go ahead.
Yeah. This is a voltage map of the right atrium. You see that looks pretty much healthy in the LAO in the left panel and RAO in the right panel. So, and these are the maps of the morphology recurrence, the electrogram morphology recurrence. So the left panel is a LAO view and the right panel is an RAO view. You see I highlighted some structure, SVC, right atrial appendage, IVC. So the blue, this is a color map of the cycle length recurrence. So goes from 175 milliseconds to 300. So in this map, we want the shortest cycle length. So, and usually you can see that the blue area are the ones that with the shortest cycle length, that in the right atrium, usually we found in the right atrial appendage, and then the septum, this area that I didn't mark here, maybe you can see my mouse, this is a 3D structure. So this should be the septum. So it's just beyond the wall that is towards us. And in the left panel, that is an LAO view, you see more clearly the very blue, the blue dots that are consistent with the septum, the right atrial septum. This is the recurrence map that we want here in this case, the highest recurrence. So we are looking for the points with the red points, and you see that there is a good correlation here in the septum, again on the right atrium, and also right atrial appendage. So the same for the left atrium. This is a voltage map of the left atrium. The pink dots represent the fractionated electrograms, and red colors for the audience means that the voltage is very low, so that it means that there is no active tissue or very abnormal or dead tissue, we can say that. And the other areas, mainly you see the RAO, this is an LAO view. The other areas, when you would like to have purple tissue all over around the left atrium, that means healthy and normal voltage tissue. But you see here that is not a healthy tissue, and you see in the posterior wall, this is diffusely diseased, diffusely evidence of intersparse areas of normal and low voltage areas here. And this is the recurrence morphology, the electrogram recurrence morphology recurrence map. In the left upper panel, this is an RAO view. You have the right superior pulmonary vein, the septum here on the back of the image, because this is a 3D image, and the left atrial appendage to the right. So in the right panel, you see all the structure. Right, this is a posterior anterior view, right superior pulmonary vein, right inferior pulmonary vein, left superior, left inferior, left atrial appendage, and septum. So here we're looking for the cycle length, the shortest cycle length, and you see the shortest the cycle length areas are the left atrial appendage, the right superior pulmonary vein, the blue dots, and also the septum, and the septum and the posterior wall, are close to the right superior pulmonary vein. Actually, this is the septum in the back, as you see here, the septum by the left atrium. And this is the recurrence percentage. We want in this map to see red dots. So, and you see red dots in the septum, by the right superior pulmonary vein, and left atrial appendage, and left superior pulmonary vein. So here I can stop, and I think I want to ask the panel, what do you do with this information?
Italo, go to the next slide.
Okay. Want me to go ahead? Okay.
So for time's sake, we'll just say that, we targeted these
Okay.
areas of short CLR. Italo, you have the pointer.
Yeah,
So
sorry.
Go
These
back.
are-
Yeah.
This is so we can see here, this is the left, we targeted the left superior pulmonary vein. This is a posterior anterior view of the left atrium, and this is the right superior, the left superior pulmonary vein. So that has one of the shortest cycle length, and we target this also. This is a anterior posterior view RAO actually, and you see that we targeted here this area. We squared this area of the septum, including also some fractionated signals, and we extended the line to the roof of the left atrium by the right superior pulmonary vein, because we had also shortest recurrence morphology electrons here. Here you can see a similar view that you can see also actually the left superior and the right superior pulmonary vein, the set of ablation lesions, and another lateral view to see better here the anterior portion of the right superior pulmonary vein. Yeah.
So we targeted all the areas with a short CLR. Just next slide.
So the guy was doing fine actually. This patient was evaluated a few months after the ablation. The amiodarone have been discontinued 6 months after this catheter ablation. But at 8 months, he had atrial flutter. So this is what happened. You see, was an arrhythmia that happened at 8 months, and then we offer the patient anti-arrhythmic therapy versus cardioversion. So he decided to do cardioversion. We performed that was successfully, and 1 year of follow-up. At 1 year, he remains asymptomatic and without atrial arrhythmias.
Yeah, we offered him ablation. But he
Sorry,
wanted to
ablation,
try a
sorry, yeah.
cardioversion. So the issue is, you do PVIs and, even by your data, even good patients, 40 to 45% of the time, it's not going to work. You bring them back. At some point we have to attack the substrate beyond the pulmonary veins. I mean, we have this protocol looking for drivers. I mean, what do you do when they come back and the veins are isolated?
Yeah, I think it's a very exciting protocol, and I really will look forward to seeing what the results look like. We've come down to I'm very convinced by the growing evidence basically pointing to the posterior wall of the left atrium. So we'll use the cryoballoon first for redo procedures. We'll re-isolate the veins, even do a little wider atrial ablation wherever the cryo hit, probably pull it a little bit. So we'll go around the veins again, and then we'll ablate the posterior wall. And that's been working really well, but we have to see over time how things hold up. I mean, the idea of these drivers, I know Al Waldo would be thrilled by your protocol where he's had mapping data from the OR that obviously you're all aware of, pointing to these drivers and unipolar signals, and the importance of drivers. So, I'll be really interested to see how this pans out. I mean, I've generally have not done much ablation in the left atrial appendage, but it sounds like with this protocol, if you have rapid drivers in the appendage, you're happy to, do you isolate the whole appendage or just ablate selectively within the appendage?
I don't like isolating the appendage because of the stroke risk, even on anticoagulation. So I've shied away from complete isolation. I either go target it or just leave it be. And, a lot of people isolate the appendage, but there are data that there's a stroke risk even on anticoagulation, which almost commits you to putting in a watchman a few months
Yeah,
later.
the issue with persist is everyone makes the argument that with persistent AFib, you need to do more, but we don't know what the more is. So I think the right approach is what you're doing, which is a clinical trial of a novel approach. We're doing a clinical trial of MRI guided computational modeling to sort of figure out what else to ablate. But I think these patients belong in clinical trials rather than just empirically doing more without data. We should be learning what we need to do by doing this kind of study. So congratulations.
Thank you. We're coming to the bottom of the hour and the end of the program. Does anyone have any quick comments? All right, so I'm going to share my screen. Italo,
Okay.
I'm going to take over from you. So next week, we have in the Miami Valves, Dr. Danny Goldstein, Professor of Cardiothoracic Surgery and Vascular Surgery Department of Surgery, Montefiore, talking about heart failure in the modern era. So I invite you all to participate. There's a seminar this Saturday from 8 a.m. to 4 p.m., heart and lung failure, mechanical support. Another exciting venture. So Miami Valves this year, obviously, we were constrained by the pandemic. Next year will be February 3rd to 5th at the beautiful Miami Marriott Biscayne Bay. Hope to see you all there. It's a beautiful time of year here in Miami. I think this concludes the didactic part of the conference. We do have exhibits, and we have a virtual exhibit by Boston Scientific for those of you who want to stay. But before we go to the virtual exhibit, any other final comments, Dr. Calkins, Dr. Goldberger?
I just want to thank you for giving me the opportunity to speak, and I loved hearing about the innovative work you're doing there. Congratulations. And I only wish we were in Biscayne Bay living it up rather than zooming in like this.
All right, well, maybe next year we'll live it up together, but we'll have to limit our alcohol intake.
Yeah.
What do
All
I say,
right.
3 drinks
Thanks,
a week or
everyone.
3 drinks a night? All right,
Okay.
thank you. If the
Bye.
Boston
Thank you, Dr.
Scientific,
Calkins. Thank you, everyone. Thanks.
Bye. Congratulations.
thank you. If the Boston Scientific people can share their screen.
Thank you, everyone.
Yep, you hear me?
Yeah,
All right, let me activate this real quick, sorry. Let me know if you see this.
Not yet.
okay, now we do.
Okay. Thank you for the time, and thank you all for the opportunity here. So I'm just going to talk real briefly about Watchman left atrial appendage closure for stroke reduction. I think you're all familiar with the therapy and with the device. It's meant to prevent or reduce the incidence of stroke, ischemic stroke, and secondarily being able to take patients off of long-term anticoagulation. Real quick, the FDA indication is for patients with non-valvular AFib with elevated risk for stroke based on CHADS VASC. And
Excuse me, we don't see your screen. Sorry.
Nico,
Okay.
we don't see a screen.
Yeah.
Apologize. Let me see here. Share. How about now?
We got it now.
Okay, thank you. And I was saying for patients who have appropriate rationale to seek an alternative to long-term anticoagulation, so things like bleeding, fall risk, label INRs, etc. Additionally, CMS has put out a memo on who is eligible based on who's unable to take long-term anticoagulation. And as you can see, the list is pretty extensive, including patients with previous bleeds, but also patients who have good reasons for not being on long-term anticoagulation. Additionally, the guidelines for AFib updated in 2019 state that the Watchman device provides an alternative for patients who have propensity for bleeding, poor drug tolerance, or adherence to anticoagulation. Our 5-year data shows a 55% reduction in disabling strokes, a major bleeding reduction of 72% long-term, and a 27% reduction in all-cause mortality, driven mainly by the reduction in hemorrhagic strokes. Recently, and this is very timely, this was presented this weekend at ACC, presentation on the NCDR LAAO registry, including essentially commercial data on over 38,000 patients who have been followed for over a year, and we have data on the long-term effects of the therapy. This is a registry that all patients are a part of. CHADS VASC score on this study, on this commercial experience, is elevated, greater than what we saw in PROTECT AF and PREVAIL studies, so 4.6 CHADS VASC score. Many of the patients, as you can see, have had a previous clinically relevant bleed, and the ischemic stroke rate is consistently low at 1.5%, comparable to some of the previous studies that we've seen. This patient population would have had a calculated imputed placebo of stroke rate of 6.6%, so it's a 70% reduction, again, based on the CHADS VASC score if they were untreated. This graph shows essentially the blue line is patient who's untreated with anticoagulation, what their expected CHAD ischemic stroke rate would be. The green line shows what it would be if treated with warfarin, and then the plots show the device arm for all of our clinical studies, showing consistently comparable to treatment with anticoagulation. And the most recent one, which I just showed, is the one on the right. Again, a higher risk patient population, but consistently performing in terms of ischemic stroke. Recently, we've launched the new Watchman Flex device. It's a device that you see on the left, built on the framework of the existing device, most studied, most implanted in the world. It's designed to be safer, particularly with the closed distal end. It's designed to have better performance both in the procedure and for complete seal, and able to treat more patients due to the shape of the device. Here's a quick presentation, a quick case study showing one of the key features of the closed distal end, which you can safely advance into the appendage. This image shows an initial deployment slightly proximal, as you can see from the T images. And then the same device was recaptured and further advanced into the appendage to then eliminate the shoulder and position it more ideally in the appendage. The Pinnacle Flex study is the study that got us FDA approval with this device and shows a event rate, primary safety endpoint of 0.5, closure of 100%, procedural success 98.8, and discontinuation of royal anticoagulation of 45 to 96.8%. Back to just to talk about a little more about safety. Mentioned 0.5% complication rate within 7 days. 0% of those were effusions requiring surgery, but interesting also, there were no effusions requiring a tap within the 7 days. So additionally, 0% embolization. So we're very proud of that. This outcome and definitely shows the safety of this device. So it's been a privilege to help treat patients with AFib and give you all an additional tool for patients with AFib. I look forward to partnering you to help more patients, and thank you for this opportunity.
Thank you very much. Certainly for our patients who can't take anticoagulation, this is a great therapy. We're now at 7 o'clock. Thank you, everyone, wherever you are in this world. And we look forward to seeing you in next year in Miami. So long, everybody.